Okay, well, as he said, my name is Dr. Lucy Bates. I am an assistant professor of obstetrics and gynecology at the University of Oklahoma, where I am actually in my very first year of teaching. I had the opportunity to come last year and present at the conference as a chief resident. So thank you very much for having me back. We really enjoy it here in Morocco. It's absolutely beautiful. So I have some objectives that I'd like to talk about today that we're going to kind of be discussing throughout this presentation. The first one is that we want to discuss the possible applications of fertility preservation in benign gynecologic conditions, particularly in endometriosis and adenomyosis. We're going to also review some fertility-sparing surgical techniques for several types of common benign gynecological pathologies. And we're also going to focus on preserving fertility and how we operate, particularly on the ovaries, but also on the uterus and the fallopian tubes. First, I wanted to talk a little bit about where I'm from. I'm from Oklahoma. It is the red state right in the middle above Texas. And this map actually came out last month from the CDC. This is a map of obesity in America. And as you can see in Oklahoma, it's very dark red. That is because the population that we have, about 40% of the women in Oklahoma are very morbidly obese. And as that obesity has increased over time, so also has the incidence of endometrial cancer. We have the only NCI designated cancer center in Oklahoma, and as you can see, comparing the U.S. incidence and the incidence of endometrial cancer in Oklahoma, that it also has continued to rise. And you're probably thinking, well, I thought you were going to talk about benign gynecologic conditions, and I am, but I make this point to say that as we've had increase in particularly women in their 20s and 30s, have a higher risk of endometrial cancer in Oklahoma, we've had to join what's called the Oncofertility Consortium, where we actually have a team at the university that when we identify somebody, whether a child or a woman who is still desiring future fertility, that we call the fertility team to be able to come in and talk to them about what their options are when it comes to fertility preservation. And we have things available to them like embryo banking, emergency IVF, ovarian tissue cryopreservation, pre-implantation genetic diagnosis, and testicular tissue cryopreservation as well. But it got me thinking, because I'm not an oncologist, are there other implications? Should we be considering these same principles, but for people who have benign gynecologic conditions as well? So it is important to recognize that fertility can be compromised both in benign and malignant pathologies, and also by the treatment required to manage them. And so fertility preservation should be discussed with each patient whose fertility may be compromised by any medical treatment or disease, regardless of what the underlying pathology is. So specifically for endometriosis, the prevalence is about 10% in the general population, up to 50% in women with infertility. And so it actually negatively impacts fertility through multiple different mechanisms. There's anatomic distortion of the reproductive tract. There's reduction of ovarian reserve, probably from pro-inflammatory cytokines, and then decrease in oocyte and embryo quality. And specifically, the one I'm going to touch on today is iatrogenic injury during operating that may potentially decrease the ovarian reserve. And so we have good data, specifically in 2014 with a Cochrane review that came out of some randomized controlled trials of stage 1 and 2 endometriosis, that surgical treatment actually improved live birth rates and clinical pregnancy rates comparing to those who did not undergo any surgical treatment. However, they also have had negative impact of surgical treatment in higher stage endometriosis, particularly in the presence of endometriomas. So following an excision of endometrioma, there was up to a 30% reduction in AMH if that endometrioma was unilateral, and up to 44% reduction in AMH if they were bilateral endometriomas. So obviously a very big hit to ovarian reserve. Interestingly, overall evidence did not support endometrioma surgery prior to IVF, as that still had similar outcomes to those who did not undergo surgical treatment. So this was a study that was done in fertility sterility in 2011 that looked at the possible causes of reduction of reduced ovarian reserve in people with endometriosis, and what they found was that the actual structural alterations that occur from these large endometriomas in apparently normal ovarian cortex actually cause this reduced ovarian reserve in and of themselves, not just the iatrogenic surgery component to it, the actual endometrioma. And that early diagnosis and intervention for endometriosis may actually be beneficial then in women with endometriomas to protect their ovarian function. So as my partner, Dr. Neal, spoke yesterday, medical therapy early on may actually help prevent some of the alterations and structural tissue alterations that we're seeing in these endometriomas as they're late stage. While with the medical suppressive therapy, we can actually potentially intervene a little earlier, which may be more beneficial to these women. Specifically, how does this compare with other types of benign cysts on the ovary? So this was a study that was done in 2019 and was published in the American Journal of Obstetrics and Gynecology that looked at tissue patterns and what the normal ovarian cortex left following a cystectomy, after cystectomy, different types of pathology. So the first was a dermoid, in which the tissue pathology overall was about 92% the same. Then a cystadenoma, which was about 77%. And then you see a pretty drastic drop when you're looking at endometriomas, that after a cyst excision, a cystectomy for endometriomas, that there's only about 19% on average of the normal ovarian cortex following of any size. And so that's very, very important for people who are considering fertility. So what are some surgical techniques that we should be looking at? I had just put on some key principles here that one, we want to identify the plane between the cyst and the ovary, because by making new planes into the ovary, we can actually then damage the cortex itself. We want to dissect the cyst wall away from the overlying ovarian tissue in a very straightforward manner, using a lot of traction and counter traction to pull apart along its natural plane. We want to be very judicious in our use of electrosurgery or cautery during that time, especially near the hilum of the ovaries. We don't want to also essentially hurt the vascular supply to the ovary. And then we want to obtain hemostasis as opposed to electrosurgery with suture if possible, because it's actually been shown to damage the ovarian cortex less than if you had used electrosurgery. So the evidence really does support oocyte cryopreservation as an effective means to preserve fertility in the setting of endometriosis patients, especially when you've discussed this and counseled patients prior to surgical management. However, despite this favorable evidence, there are some concerns in three specific areas. One is that we don't have good data yet, there's still studies, about how effective that oocyte preservation is in endometriosis patients. There is some decrease in knowledge on the quality of what those vitrified oocytes look like, because we already know that at baseline, people with endometriomas have that have the cytokines, have the inflammatory process going on, that those oocytes may in and of themselves not be of very good quality. And then we don't really know what the cost effectiveness of oocyte cryopreservation would look like in this population specifically versus in people with malignancy where we have good data. But what would that look like essentially? In patients who desire fertility with endometriosis, then you could ask them if they're considering immediate fertility versus future fertility. So this would be important in younger women, pediatric and adolescent gynecology populations versus people in their 20s or 30s. And then you could consider spontaneous or IVF pregnancies in those wanting to immediately pursue pregnancy, but in those who desire pregnancy in the future, you could consider ovarian reserve testing. And if it is normal, and then they are less than 35 years old, consider fertility preservation if you believe that they are at high risk of having low ovarian reserve. So the second thing I wanted to chat about really quickly is adenomyosis, and specifically uterine sparing surgical treatment. So the excision or destruction of tissue within the myometrium to take out the diseased tissue, but leave as much of the healthy myometrium. That's the goal of conservative therapy. This is all pretty relatively new. Adenomyosis infiltrates the myometrium, and so there is always an associated damage to some myometrial tissue when you are removing some of the adenomyosis. But we do have some classifications of surgical techniques. One is complete excision of adenomyosis. So if you have have one specific area on MRI, you might be able to completely remove all of it. And then the other one is a partial excision or cytoreductive surgery, which is essentially if a complete removal of all the adenomyosis would lead to a functional hysterectomy, meaning you would remove too much or damage too much of the myometrium, then a partial removal may be helpful still. And then there's some non-excision techniques, as we heard yesterday, that the radiofrequency ablation may be soon applied to adenomyosis as well. And then a couple other pathologies, just really quickly as we finish up, that I wanted to touch on when we're looking at, as benign gynecologists, trying to preserve future fertility for our patients, is what we do in a couple of very key situations, one of which is ovarian torsion. So detorsion has the potential to preserve ovarian reserve, and it should remain the optimal treatment in girls and premenopausal women, meaning that we're not doing oophorectomies at the time of torsion, that detorsion alone, and sometimes oophoropexy is usually sufficient. And so following detorsion, ovaries were found to be functional in greater than 90% of patients who underwent detorsion alone and not removing the ovary. And so when that adnexa was assessed postoperatively, they still had normal appearance, including follicular development on the ovaries. And so even as you can see in this situation with several torsions around the adnexa, this patient went on to have 2 spontaneous pregnancies without issue. And then lastly, what to do with ectopic pregnancy surgical management and whether or not to perform salpingostomy versus salpingectomy. And there were some randomized controlled trials that demonstrated that there was no statistical difference in rates of future intrauterine pregnancies or repeat ectopics between the 2 routes. However, in a large cohort study, they found that salpingostomy does have a slightly higher rate of subsequent intrauterine pregnancy, but also an increased risk of recurrent ectopic pregnancy. And so from our American guidelines, we consider salpingostomy only in patients who desire future fertility but have a damaged contralateral tube. If the contralateral tube is normal and healthy looking, we will typically recommend salpingectomy for ectopic pregnancies in that sense. And so this is just a quick picture of the 2 differences. So just a couple conclusions. There's definitely more data needed in comparing fertility outcomes and cost effectiveness of oocyte preservation in the setting of benign diseases. And then in patients undergoing surgical intervention with suspected severe damage to the ovary or to the uterine structure, consider counseling about fertility preservation, not just in those with malignancy, but in those also with benign pathology. And so I think there's some opportunities for oncofertility practices to become practical tools, not only for the oncologist, but also for the benign gynecologist as well. So thank you.